Be looking for that. And I am delighted to introduce a gentleman that most of you already know, Dr. Timothy Lichtleiter, who is a dear friend of the foundation, and I will turn it over to him.
Thank you, Christy. You did a great job. Just as good as Casey. Casey's on vacation from what I understand, but I guess she'll be back. So you're just stuck with me. Well, welcome back to the party, everybody. I am Tim Licklider, sitting here in my office at Allegheny General, where I normally am. In scrubs again today because yet again I am on call this week, although theoretically that's two months in a row. I think it's spaced out after this, so don't worry. But that does mean if I get an important call, well, you guys are put on hold because, well, here pays me and this doesn't. Um, it's just the way it works. I am a so-called movement disorder specialist. That means I did some extra training in movement disorders. For if you don't know me, welcome to the party. If you know me, welcome back to the party. Things I always tell people is, this is a great place to ask questions. So type them in the chat box. I actually did not get too many in the email. I only got a couple. So this will either be a short conversation or you guys will fill up the chat box with questions. If you have questions, particularly questions that pertain to maybe everybody, that's probably better. This is not a great place to get specialized or specific one-on-one care. Most likely, I'm going to say you should really check with your neurologist because that's probably the best way to do it. And as I mentioned, this is all my opinion. So that's what you get. My opinion is just that. Take it for what it's worth. I like to think my opinion is based as close in scientific evidence as we have, although we don't always have that kind of evidence. And sometimes I do indeed make stuff up. And if you go to somebody not me, then they may have a difference of opinion, and that's okay. That's just how the world works, particularly in movement disorders, where we do have a lot of gray area. Let's just put it that way. So feel free to type your questions in the chat box down there, and I will come to those after these couple of questions that I got in emails, and we'll go from there, even though it is indeed raining. Hopefully everybody's staying dry. Although we needed rain. It hasn't rained in a while. And I'm drinking lemon lift for anybody who is wondering, then yes, I did spill it on myself before. So the first one I got was actually from my patient, and this sort of breaks my rule, but I'm going to sort of break it because I think it lends itself to everybody. This was really asking about a specific treatment option for themselves, but I'm going to generalize it to everybody. But I've been having lots of changes in my symptoms of Parkinson's disease, a lot more pain. My ankles are stuck in cement. Not being able to bend my ankle is extremely painful. I do have deep brain stimulator implanted, but not sure if this is related or DBS should take care of that. Because of this, I fall more, blah, 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 which everybody understands. Falls are not your friend, they're your biggest enemy. Um, the question really is I'm guessing Parkinson's disease is progressing, and the short answer is yes, but I had prescribed Lyrica for pain. And their question, after reading all the potential side effects of said medicine, which there are a ton, the question is, hey, is this a great idea? And so I think pain is really important. I'll sort of answer that question, but I think pain is really the question because I do get that a lot, and it is kind of an issue in Parkinson's disease. And so pain is a tough one because there's a lot of different kinds of pain in my patients, and teasing through the different types is really the important part to try to figure out what do you do about it. Pain can be from Parkinson's disease itself. So the stiffness itself can lead to pain. And I'm wondering if that's what's happening here. If you're rigid or you're tight, that can lead to muscle cramping, that can lead to pain, that can be a pain syndrome in and of itself. When you're tight or when you don't have proper mechanics, that also leads to a lot of joint problems. And so a lot of my patients have a lot of arthritic changes and degenerative changes in a lot of their joints. Again, when your walking mechanics aren't correct, when you're flexed forward, when you're taking short shuffling steps, when you're not swinging your arms when you walk, that puts and the posture mechanics that come along with that, that puts a lot of stress and strain on your joints that are not intended for your joints. You were put together correctly the first time. Your joints were designed for proper mechanics. And when you don't have proper mechanics, that wears through joints. So I see a lot of patients with neck problems, shoulder problems, back problems, hip problems, knee problems, ankle problems too, but more the others. And so that often leads to a lot of pain. When patients wear off or when they have quote unquote off spells, and yes, I know the next question is going to be, I don't have on times or off times. Believe me, that's not a universal, but a lot of people do. And when you have off times, sometimes that in and of itself comes with pain or is very uncomfortable to say the least. Not outstanding are the fact that a lot of other pain things come along with aging and typical, progression of everything. And so neuropathy can be painful. Other medical conditions like gout or pseudogout can be painful. So there's a lot of things that can lead to pain in a lot of my patients. And really trying to tease out what the underlying cause is probably the best way to work on it. Coming back to this case, if it is indeed a stiffness problem, then maybe that is more of a dopamine problem, and maybe DBS would help with that if we could adjust it, or maybe adjusting Parkinson's disease medicines would help. Sometimes if it really is a stiffness problem, or sometimes even if it's a posture problem, a little bit more medicine can help with that. Not always. If it's truly a neuropathy problem or a neuropathic pain problem, then yeah, Lyrica is a great drug. Yes, it has side effects. I do not have a side effect-free medicine. No, I don't think I have a medicine that's going to help with neuropathic pain that doesn't come with the same potential side effects or worse than Lyrica, gabapentin, and that class of medicine. It's not the only medicine we have, but at the end of the day, it is a good medicine. And the hard part for people and a lot of my patients to wrap their head around is I don't have a side effect-free medicine. And yes, often, not often, sometimes, maybe oftentimes, the side effects are potentially worse than whatever problem I'm trying to fix. It really comes down to a risk benefit ratio, or the potential benefits, meaning is the pain that bad that we have to try something knowing full well that it could potentially cause another problem? That's really something that you have to decide. Um, if it really is, again, coming back to a mechanical problem, maybe it's a posture problem, then I send a lot of patients to physical therapy to work on your mechanics and things like that. And so trying to tease through the different types of pain that come along with Parkinson's disease or posture mechanical problems or neuropathy or nerve problems, I mean, is very difficult because, I ask you, and I know I recognize that's a hard question to try to answer. You're not exactly sure what's causing it, and you have a hard time explaining it. And I get that. But the more of a conversation we can have, trying to see is there any correlation with medications, with time of day, with what you've done. All of these things really help us try to figure out what type of pain are we dealing with, what is the underlying cause, and then I think we can better try to figure out what's the best strategy for it. That's really because I get the pain question a lot. And that's why, even though that was a specific question for one of my patients, I really do think that extrapolates to everybody. Pain really is a fairly widespread problem. It's not just a one or two off type of problem. It is a problem that I get quite often. And that's why it's so difficult to try to figure out because there's a lot of different things that can cause it. And really trying to get to the underlying cause is how we try to get to the solution. So I thought it was a reasonable question to talk about. And I like the other question that I got in my email too here, which is when a Parkinson's disease patient is on numerous cardiac meds to reduce blood pressure and pulse rate, resulting in extreme fatigue, how is it possible to exercise to the point that is so important for patients with Parkinson's disease to do? Any suggestions for having a patient exercise to the point where there's appropriate cardiovascular circulation that is so important for the brain? Hard to accomplish whenever the blood pressure meds and cardiac meds result in extreme fatigue. Yep, I can't argue with any part of that question or conversation. And not only that, how do you get your heart rate up if you're on medicines that are aimed and designed to specifically lower your heart rate? All of these are good questions, and they don't have easy answers. My answer is when I'm asking you to exercise, which is all the time, because exercise really is the best medication for everything, particularly from a Parkinson's disease standpoint. The idea is that it's work. Yes, heart rate is a measure of that. There is a target heart rate, 220 minus your age, that's your peak or max heart rate, and we're aiming for 80% of that. That's the statistical number that you'll read in a textbook. But when it comes to day-to-day practice, it just has to be work. Yes, it would be nice if you could get your heart rate up, if you could get your blood pumping. But if you're breaking a sweat, but your heart rate is still 80 or 85, it still counts as work. Exercise is really more than just day-to-day activity. You know, I know that because every time I say, hey, you need to exercise more, I get the whoa, whoa, whoa. Dr. Licklider, I'm active. I'm up and down the steps 10 times a day. I do laundry. I take the, you name it, insert, housework or typical day-to-day activity in there. And I say that's great. Being active is better than being inactive, but we need more. Exercise is more than just day-to-day activity. Yes, it would be nice if you get your heart rate up. Yes, it would be nice if you're breathing a little heavy. Yes, it would be nice if you're breaking a sweat. There is a graded kind of variant of how good it is. The more intense it is, generally the better. But if you can't get your heart rate up or you can't, really work to the point where cardiovascularly you're getting things up because you're on medicines to prevent that, it still counts if you're breaking a sweat, you're doing more than typical day-to-day work. So I don't personally tell my patients, you need to push it until your heart rate is a certain number, or you need to get your blood pressure up or your heart rate up, because I do recognize those are not always easy, and there are often medications that are impacting or interfering with that. But it really does, you still have to do it. That's not an excuse not to exercise, and you just have to do the best you can. Again, what I'm looking for when I'm talking about exercise or thinking about exercise really is more than day-to-day activity. Breaking a sweat is what I'm aiming for. And if your heart rate doesn't go up above 100 because you're on medicines that control that, so be it. It still counts. It's still good for you. Do the best you can. But that's not the first time I've had that question. That's a very reasonable and good question. And I hope that gives you the perspective of what I'm looking for from an exercise standpoint, what my definition of exercise is. Again, exercise is more than day-to-day activity, and the more you can do, the better. The reason why I talk so much about exercise is because it really is the most important thing for you. At this point, it's the only thing that we think or are relatively confident in terms of being disease modifying. We have not had success coming up with disease modifying medications, interventions, and treatments. And so, because exercise potentially does that, it's even more important than the pills and the medications and things like that. It really is the absolute best medicine for you. And you can't say, well, I'm not going to exercise because my heart rate doesn't go up. That's a bad philosophy. All right. I think I've beat that one to death. But those were the only two questions I had in email. So now I got to go to the chat box. How does one overcome an intolerance, nausea to carbidopa levodopa? Well, that's a great question. Two choices. One, you stick it out and it gets better, or two, you don't. And I don't know by talking to you or trialing it or looking at you which it's going to be. So I have had patients, carbidopa levodopa is the best drug that I have. It's been around since the late 1960s. It's been around for a long time. Still the gold standard for Parkinson's disease. Don't even get me started on my frustrations with that. My frustrations are your frustrations. Yes, I wish there was something better, but there isn't. The biggest and most common side effect of carbidopa levodopa is upset stomach, nausea, vomiting. That's about 10% of people statistically. And I have seen both. I have seen patients where I put them on carbidopa levodopa and it makes them nauseous. And then I say, we'll take it with food. Yes, I'm well aware that it works best on an empty stomach, but if you take it with food, it tends to help with the nausea. And it does help. And then after a while, they get used to it and they're able to take it on an empty stomach. And as their disease progresses, I can increase it without making them sick. I have seen that. And so sometimes waiting it out or pushing through it does help from a nausea standpoint. However, I have also seen that no matter how slow I go or low of a dose I start with, or how long we put in between increasing dosages or ramping it up, and no matter how much food they take it with, and no matter how much extra carbidopa I add to it, or no matter how much Zofran I have them take with it, it still makes them ridiculously sick to their stomach. And they never get used to it. And I haven't figured out how to predict that. I don't know of any way that I can look at somebody and say this is going to get better or no, it isn't. And so it really comes down to how much it bothers you. Yes, again, I have had patients where they get used to that nausea after they're on it for a while and they develop a tolerance to it. But I've also seen people who don't, and we can't use carbidopa levodopa, which is very frustrating because it really is the best medicine I have. Thus, I would say, since it's the best drug that I have, maybe stick it out for a little while, see if maybe we can half the dose or go up at a slower interval level. If you're not taking it with food because you've been told that levodopa works best on an empty stomach, try taking it with food. I'd rather you get some benefit from it than none. And if that's not good enough, then maybe we layer in something else to help with the nausea to see if we can get you to tolerate it better. But the short answer is it's a lot of trial and error, much like everything else in my world, and you just have to kind of see how it goes. I started waking up choking on my saliva. Any advice? Yep. And so there are some things we can do. So drooling, fancy word is sialorrhea, is pretty common in my office. So a lot of my Parkinson's disease patients, for a lot of reasons, tend to have saliva coming out. A couple of those reasons are: one, generally my patients tend to sit flex forward and their mouth hangs open, and so gravity does the work for them. Two, because a lot of times you don't sit with your mouth closed and your mouth kind of hangs open, those secretions tend to dry up, come out, get thicker, and then they become more of a problem. Three, because just like a lot of my patients are generally people with Parkinson's disease have what's called a masked face. So you don't blink as much as most people. You also don't kind of as much as most people. You don't swallow your saliva as much as most people. And so fluids tend to hang out a little bit longer. And again, as they thicken up and gravity takes over, they tend to come out. And so there's a lot of reasons why I run into this problem a lot. Sometimes people do describe it as a nighttime phenomenon, or it wakes them up because secretions are pooling kind of as they're laying on their pillow. They're not moving a lot because they're stiff, and people with Parkinson's disease don't roll over a lot or move a lot at night, except for when they have REM behavior sleep disorder, which makes them act out dreams. And so maybe secretions are pooling in the back of their throat, and that's causing choking to get and to wake up. There's a couple of solutions or things that I try for the saliva problem. What I've had best success with personally have been botulinum toxin injections. Now, the downside is what I've had the best success with is something called MyoBlock. MyoBlock is a specific type of botulinum toxin. It's, everybody thinks of Botox, but Botox really is a brand name. MyoBlock is a different brand name. They're both botulinum toxin injections. They're just different. However, MyoBlock has been on back order and not made, I think, for at least the past 9 months, if not a year. And I have not heard of anything in terms of that changing. Both Botox and Xeomin, which are two different botulinum toxins, are also approved for sialorrhea and Parkinson's disease, and I have had still reasonable success with those ones. And so since lately I have not been able to get MyoBlock, that's what I've been using. And if we don't want to do injections or those don't help, we do have some pills that we typically use. The one that I probably use the most is glycopyrrolate or Robenol. Second, I use atropine drops under the tongue. Sometimes you can use a scopolamine patch. And that's kind of the order that I would go into it or go through it. I've had the best success with injections into the parotid gland and the submandibular gland. Yes, it is injections. Yes, I have to jam a needle into your face a bunch of times, but that's what I've had the best success with personally. But we can also use pills or drops or things like that. If I was trying to work on that saliva problem or that choking problem at night, that's probably what I would try first. I would also probably say speech therapy is really helpful when it comes to swallowing things or saliva problems to some extent. So sometimes speech therapy might help, but those are probably the routes that I would go to see if we could work on that. I have had some people with that specific problem, waking up choking, who do respond to injections and that improves it, but I've also had people who don't. And so again, much like the answer to the first question, a lot of what we do is trial and error, and we just have to see if we can work on that problem. Is there any evidence that mental exercises like playing Jeopardy every day is beneficial to the Parkinson's disease brain? Yes and no. And actually, I believe it was on a talk here. Geez, I don't know when it was, a long time ago, where I actually learned about something I'm having a mental fart on. Brain HQ, and speed of processing. So there is some evidence in speed of processing brain games to actually help cognitive decline, and not just people with Parkinson's disease, but people with memory problems and everything. That's the only actual good evidence that I've seen for brain games or for kind of those kind of things that shows any good evidence that it does help dementia, cognitive reserves, memory problems in general. My personal take, and we've looked at things like crossword puzzles, Sudoku. These are hard things to study. The data is kind of not very good. My personal opinion is that yes, your brain is just like everything else. If you don't use it, you lose it. And the more you use it, the better it is. Um, I do think trivia, doing crossword puzzles, doing brain puzzles is good, even though there is not very good data in your basic brain games and things like that. I still think it's better than not doing anything. I personally recommend, if somebody really asks my opinion, I think learning a new language is the best. That really puts you in a tough position. Not that I think I'm ever going to learn a language, but I myself play on Duolingo pretty much every day. I'm getting relatively decent at doing the Italian lessons. I'm questionably doing German because my daughters take German in high school, and well, I'm not very good at it. I tried dabbling in French, but French is really hard. Chinese is probably the absolute hardest, but I dabbled in that for a little while. But again, these are things that I think just help you develop more cognitive reserve. I have to assume, and this is an assumption, this is based in no fact whatsoever as far as I've ever seen literature on, the more you learn, the better it's going to be. I do think that taxing your brain by learning a new language, learning a new subject, playing a new instrument does indeed sprout new nerve endings or connections, which can only help. I have no evidence whatsoever ever to back that up. I don't believe there's any literature outside of the speed of processing literature that actually supports anything that I said, but I personally really do think that it helps. I really do think that if you're somebody who just scrolls on TikTok or watches TV and doesn't do a lot of thinking, you are putting yourself at a disservice. And I really do think the more new things you can learn and the more challenging things you can do for your brain is really going to help you in the long run. You can quote me on that if you want to. I did make that up, but it makes sense to me. And so, yes, I do think playing Jeopardy is a great idea. I don't think that's going to solve Alzheimer's disease. I don't think that's going to solve mild cognitive impairment or heading towards dementia. But is it going to help a little bit? Maybe. And I think it's at least worth a try. It's better than doing nothing. Those are all my opinions. Since depression and or anxiety is common in Parkinson's, how can this be managed? Great question. We know that anxiety and depression are huge. So statistically, both are about 50%, maybe 40% for anxiety, 50% for depression. But I think those are lowball numbers. I really do think if I actually looked at the vast majority of my patients, there is at some point in time some component of anxiety and depression. If not 100%, it's at least in the 80 to 90% range. I think those numbers are extremely low, and that's just what happens when you do surveys or you ask people. You're not going to necessarily collect everybody. And so, yes, I really do think anxiety and depression are huge in the Parkinson's disease world. I think they are very, very common. And I think they are indeed things that we need to do something about. I do not think they should be ignored. I would argue that when anxiety and depression are not well, I don't want to say controlled because that's not the right, addressed is probably the best way to do it. Addressed, thought about, talked about, and potentially treated. If that's not happening, it will significantly not only impact your mood, but also your cognitive abilities and your physical abilities. I really do think that if we ignore those kind of things, everything takes a hit and gets worse. And not just because physically you feel worse, but then you're not going to exercise because you're apathetic or you're depressed or you're anxious about things like that. You're not going to do the other things I want you to do. You're not going to do a lot of the things that I need you to do to give yourself the best chance of doing the best. And so I really do think it is important that not only is it talked about, it's got to be brought up, it's got to be asked about by people like me, and it has to be addressed. Now, it can be addressed in a lot of different ways, and everybody is a little bit different, and everybody wants something a little bit different. Everybody feels like there is a best way for them to treat or manage or understand or tackle their mood problems. Some people do well with therapy, talking to a therapist, talking to a psychologist, and that is a good way to not only grapple with what they're dealing with, but come up with good coping strategies or mechanisms to help them get through day-to-day life and deal with it better. Some people have absolutely no interest in talking to a therapist and would rather be on a medicine, which we do have. We have, and I don't know why they had to do studies, but they did indeed do studies on some of the antidepressants in people with Parkinson's disease. And guess what? They work in people with Parkinson's disease too. You guys aren't that special. Sorry. The antidepressants and the anti-anxiety medicines work for people with Parkinson's disease, anxiety, and depression too. They've proven this. And so there are medicines that we use for these kind of things to see if we can help. I can use some. I am not a very good psychiatrist. No offense to your primary care doctor, they are also not a very good psychiatrist. Psychiatrists specialize in anxiety and depression. So don't be surprised if you come to me If we're not doing well from a mood standpoint, I'm going to suggest that you should go to a psychiatrist. And I have never met a patient who's like, yeah, I love that idea. I have met a lot of patients that say, what do I need a psychiatrist for? I'm not a crazy person. And I say, I know you're not a crazy person, but this is the specialist for the problem that you're dealing with. You come to me because I'm good at Parkinson's disease, and that's what I have a lot of experience dealing with. You go to your heart doctor because you have atrial fibrillation or congestive heart failure. You go to your endocrinologist because you have bad diabetes or thyroid problems. Well, guess what? The same is true for mental health and mood disorders. And ultimately, a psychiatrist is going to be a much better person at medications, combination of medications, different medications that are really tailored to you and your specific problem. We do use different medicines for anxiety as we use for depression sometimes, and there's a whole variety of things we can do, but a lot of times we do need help from a psychiatrist to figure out the best way to manage it. So if you're my patient, don't be surprised if I suggest it. And if you're not my patient and your doctor, your neurologist, your primary care doctor suggests a psychiatrist, it really is because that's the absolute best person who specializes in that problem. But the short answer is medications, therapy, a psychiatrist, exercise. Exercise is a great antidepressant and anti-anxiety medicine. All of these things used in combination are probably the best way to work on it. But the key to success is talking about it. The key to success is bringing it up, especially if it's not being very well managed, or especially if it really is impacting your day-to-day life. These are things that should not and can't be ignored, or you will not have a lot of success or not as much of success as you should have. And so the step one is talking about it. Step two is figuring out what will work best for you. What are you interested in trying? How aggressively do we need to tackle this problem? So on and so forth. If it's particularly bad, sometimes I do things, and there's some evidence behind transcranial magnetic stimulation, and they're dabbling in that in tremors and Parkinson's disease as well. And so there are things that can be done. And again, step one really is bringing it up and having a conversation about it so we can figure out what to do about it. What can you do if carbidopa levodopa meds cause dyskinesia? A couple of things. And so dyskinesias are kind of squirmy movements, extra movements. I always say if you've ever seen Michael J. Fox on TV and you see him constantly moving, that's a dyskinesia. So that is indeed a side effect of the medication. And it's not just carbidopa, levodopa. All of the Parkinson's disease drugs theoretically can do it, with one exception that I'll come to in a minute. But the higher the dose, usually the more it is. Now, not everybody gets dyskinesias. You don't have to go looking for it. And some people, even when they have it, they either don't notice it or they don't mind it. A lot of patients find they're dyskinetic when their pills are at their peak, and that's also when they feel at their best. And so they can overlook the extra movements because that's when they move and they can function the best. That is not true for everybody. There are plenty of people where dyskinesias are really bothersome and we have to do something about it. But just like everything else that comes into my office or in my world, how much is it bothering you? How much is it impacting your day-to-day life or your quality of life are really the questions that I have to ask to figure out what do we do about it. Generally, because dyskinesias are a side effect of the medicines, carbidopa, levodopa, pramipexole, verapamil, vertigotine, you name it, it can cause dyskinesias. Option number one is cutting back the medicine. If we decrease the medicine or if we take the medicine away, we can stop the dyskinesias. Now, the hard part about that is if we decrease the medicine or if we take the medicine away, you may not move as well. Again, the medicines are aimed at tremors and stiffness and slowness of movement and walking. And if we decrease or take away the medicine, those things could potentially get worse, assuming your medicine is helping treat what we think it should help treat. But if we can find a happy middle ground, if we can back it down a little bit to the point where you're still moving, maybe we had you on too much medicine to begin with, and maybe we can get away with a lower dose, maybe that will at least dampen down the dyskinesias to the point where they're at least tolerable. The other option is amantadine. So amantadine is an old drug. It's been around for 100 plus years. Gocovri is the newest version of it. It's a kind of a fancy formulation that is specifically targeted to dyskinesias. But amantadine is the one drug I have that sometimes, not always, in some people, not only helps tremors and helps you move a little bit better, but can decrease dyskinesias. It's really the only medicine that we know of or that we have that can specifically not only target Parkinson's symptoms, but also decrease dyskinesias. There's a couple of other potentially looked out medicines that aren't necessarily all that proven, but adding in something like amantadine or Gocovri would be a way to also try to help decrease dyskinesias without potentially having or the need to decrease your current Parkinson's disease drug regimen. That's the other way that we try to go about it. If dyskinesias are incredibly a problem and we absolutely can't decrease medicines or amantadine isn't doing the trick, then sometimes that does make us think more along the lines of more aggressive things, deep brain stimulator surgery, high frequency ultrasound ablation, things like that. Um, with the idea that oftentimes it does allow us to cut back your medicines and helps kind of decrease dyskinesias. Now, I have run into patients where DBS causes dyskinesia, so it's not a fix-all or a cure-all, but these are really the options that we have when we run into dyskinesias as a problem. Again, it's a side effect of the medicines we use to help you move, and so that kind of weighing out which is more important, which is more bothersome, and can we find that happy middle ground is really the best way to try to do it. The medication wearing off in the middle of the night leads to lack of sleep. Yep. I can't tell you how often I see patients and they say, you know what? I take my pills every 4 hours when I'm awake, and it does great. It doesn't wear off. I feel good. I don't really have a lot of problems or ups and downs during the day, but man, the middle of the night's a different story. I go to bed at 10 o'clock, and literally every day at 2 o'clock in the morning or 3 o'clock in the morning, I'm awake and I can't get back to sleep. And I say, yeah, that doesn't surprise me at all. If your pills are only lasting 4 hours during the day and you take your last dose at 10 o'clock, 4 hours from then is 2 or 3 o'clock in the morning. That's not all that shocking to me. And sometimes you enlighten people when you throw that out there. They're like, "Oh yeah, I never really noticed that or paid attention to that." But sometimes wearing off in the night does wake people up. Or if it doesn't necessarily wake people up, they wake up to go to the bathroom or get a drink or do something. It does inhibit their ability to A, get up and move or get to the bathroom, but B, get back to sleep. And so then they're tossing and turning and they're miserable. So that's not an uncommon thing that I hear in my office. It's not an easy thing to fix. And it's not an easy thing to fix because we don't have very good long lasting pills, as we've talked about in many times around. The major downfall to the majority of the medications that I have for Parkinson's disease is that they are short lasting. And that is true for carbidopa, levodopa. There are longer lasting versions, and so this is where you will see me use both the Cinemet CR version, which I don't like to use during the day because it doesn't work as well, but sometimes it does last a little bit longer at night, or Rytary or Crexont, which are newer versions of both immediate release and controlled release carbidopa, levodopa. This is where you'll also see me use a Nupro patch because the patch you wear all day and all night. This is maybe a plug for some of the newer pump therapies that are becoming more available. Or maybe, again, we need to think of something more aggressive. Deep brain stimulation is something that you have consistently. And so trying to come up with something that bridges that nighttime gap is oftentimes difficult with pills and really a difficult problem across the board. Now, I have a lot of patients who say, well, what if I just take a pill when I wake up in the middle of the night? I say, try it out and see what happens. I'm not telling you what to do if you're not my patient. Not even really telling you what to do if you are my patient. We should probably talk about it. But at the end of the day, I do have patients who take pills in the middle of the night. I am never somebody who says you should set an alarm and wake up and take a pill. I never think that's a good plan. But if you're already waking up in the middle of the night because you have to go to the bathroom or because you have to get a drink or because your pills wear off, if you're my patient, I would probably be reasonable and say, yeah, try taking a pill, see if that kicks in, see if it helps you get back to sleep, see if it gets you back on the right track. Sometimes the inhaled version called Ambrosia works a little bit quicker. So there are these ideas or these strategies that we can use. But the short answer to really wasn't a question, more of a statement is a lot of times when pills wear off over the middle of the night, it does wake you up. Or if it doesn't wake you up, you do wake up, it makes it harder to go back to sleep. And there are some strategies, not a lot, not great, but some strategies that we can try to minimize that and see if we can get you doing better. Anytime the question starts with, can PD cause? The answer is yes. Doesn't even matter what the rest of the question is. The answer is yes. Can Parkinson's disease cause extreme daytime fatigue and brain fog? Absolutely. In fact, I would argue fatigue, lethargy, tiredness is probably the number one complaint that I get in my office. Frustration is the number one theme in my office, but tiredness and fatigue is the number one complaint I get in my office because everybody is tired. The disease makes you tired. The medicines make you tired. Getting older makes you tired. Other medical problems make you tired. Everything makes you tired. And all of those things add up to make you even more tired. And so, yes, the short answer to the question is, and brain fog is very similar. A lot of my patients have certain times of day. Sometimes it's in the morning, sometimes it's in the afternoon, sometimes it's all day long where they do have a lot of brain fog and cognitive changes. The second question is much more difficult, which is what can be done to help with this. That is actually a really difficult problem. And I'll start with the brain fog because there really isn't anything designed for brain fog. Sometimes I'll try amantadine that's helped maybe in concussion patients. Sometimes I'll try the Alzheimer's disease drugs to see if that helps with clarity, but really I haven't come up with a lot for brain fog. But those are the things that we have to try. The fatigue problem is a much more common problem and a much more difficult problem, and here's why. So I've tried everything. I have tried literally everything known to man that you can possibly think of, medication wise or treatment strategy wise, to help with that fatigue. I have tried more dopamine medicines. I have tried antidepressants. I have tried anti anxiety medicines. I have tried stimulants. I have tried other things that don't even seemingly have any business being tried in fatigue and energy. And I have yet to find a medication that actually solves the problem. The only thing that I've ever come across over my past 10 years of doing this that actually helps from a fatigue and energy standpoint is my favorite topic, and you're going to get tired of hearing about it, which is exercise. Now, the obvious question, how the heck am I supposed to exercise if I'm already tired and fatigued and don't feel like getting up and doing anything? And that is a great question that I do not have a good answer for. But if you can find a way, getting up, being active, moving will indeed help with that energy level. I have a lot of patients who find that early afternoon, 2, 3, 4 o'clock time are really down times. Um, at one point, I was trained that maybe that's the time everybody naturally makes the least amount of dopamine. I don't know if that's based in fact or that was just made up, but that's ingrained in my head. But that is a common time that a lot of patients have down times. And I don't want to be the bearer of bad news, but if you're sitting in your comfy chair and you're watching TV and you're not stimulated, you're going to fall asleep. And it doesn't matter what time of day it is. And yet, if you were up and you were out of the house and you were walking and you were stimulated, you will be much less likely to be tired, fatigued, and fall asleep. Now, again, how do I get you the energy to get up and get out and do that? I have yet to figure that out. But as soon as I do, I'm going to let every single one of you know because that is the most common and biggest problem in my office. And if I came up with a solution for that, well, then I could probably retire. The reason why it's such a hard problem is this is not my opinion, this is not a physical fatigue. This is not, I just went to the gym and did a heavy workout and now my muscles are tired, or I just went and ran a marathon and I'm physically tired. This is a mental fatigue. And it's a mental fatigue because you spend all day having to think about things you shouldn't actually have to be thinking about. Take big steps, talk at a loud voice, be careful when I stand up, pay attention when and take extra steps when I turn, do things bigger, move that arm. Things that should naturally happen don't. They can happen, and you make them happen by putting extra brain power and thought into doing it and making it happen. And when you have to use that extra brain power and thought to make day-to-day things that should just naturally happen, it is exhausting. And that is why I have yet to find something, and that's my opinion. No, that's not scientific. That's just what people have told me and how I've put it together. But that's why I think it's been such a struggle for me to find a medicine or something that solves that problem. I would have to find the cure for Parkinson's disease, I think, to solve that problem, and I have not found that yet. Because I really do think it is an ingrained part of all of the extra brain effort that you have to put forth to make that happen. Doesn't mean it's not a problem, doesn't mean we shouldn't talk about it, doesn't mean we shouldn't try things, but just be aware that it's an extremely difficult thing to work on. And realistically, the best medicine for everything is getting up and being active and exercise. Yes, I know it's incredibly difficult to do. If it were easy, everybody would do it and I wouldn't have to yell at anybody, but I do. It is difficult. It does require motivation and energy, but if you can find a way to do it, it will indeed help with those problems. That is a great question. Are there any general indicators that can predict speed and severity of Parkinson's disease symptoms? My first answer to that question would be no, is that we are not in a place where we can look at somebody and say, because you have this, it's not going to go well. Now, there are some markers that have shown in studies to portend worse symptoms. But for every study that I see, I can come up with a patient that has that has done well. And so I don't think they are that reliable. For instance, I'll go historical. We used to historically think that tremor predominant Parkinson's disease was better than the akinetic rigid. Some people present with a lot of tremors. Some people come in and are just very stiff. And we used to think that the stiff people did worse, that they would progress quicker. But every single one of me or every single movement disorder specialist has plenty of patients that come in stiff who have done very well. And that has not been the case. And so now we usually don't even classify or break down people based on presenting symptoms because it's not really all that helpful. I do think I will have a better answer for this question when we actually solve the problem of what triggers or what causes or what quote unquote type of Parkinson's disease you have. And so this leads me to the current state of affairs of what we're trying to accomplish in Parkinson's disease. We don't really know why people get Parkinson's disease. We are learning more and more about this, and we are doing a lot of work to try to figure this out, but we haven't quite grasped it yet. As we do more genetic understanding and we start teasing out more and more of the genetic underpinnings or causes of Parkinsonism, as we delve into the environmental triggers, which there's huge talks about these days, in terms of what triggers it, as we start to get to the underlying specific genetic/environmental type of Parkinsonism that you have, then I think we will have indicators for, okay, this specific type does this specific type does this specific type acts like this. And along with that, I also hope comes this is the best medicine for this specific type. This is the best treatment strategy for this specific type. This is the definition of precision medicine, which really is the gold standard. We're nowhere near that, at least in my opinion. But I think once we can start doing that, then I think we'll have better indicators that will predict speed and severity and endpoint and treatment options and surgery options and who does better with what. And I think that really is what we're aiming for, what we're trying to accomplish. We're just not there yet. So more to come. But I would argue that as of today, I am not very accurate at looking at you, looking at specific markers and saying this is going to be good or bad. I don't feel that confident that I have that ability, and so I wouldn't do it. What is my opinion of Imbresia, the levodopa rescue inhaler? It's okay. It works in some people. It doesn't work in some people. Some people like it, some people don't. So this is inhaled levodopa. It's theoretically a rescue medicine. So for people who do have on-off phenomenon, if you wear off unpredictably or even predictably, we can use the inhaler to try to jumpstart your medications and get them to kick in quicker. Generally, it takes about the inhaler about 8 to 10 minutes to kick in, whereas a lot of people notice it's about a half hour, 45 minutes, even an hour for their pills to kick in. And so that's the idea. It's not as potent as the pills, but it works quicker. And I have some people that really like it. They use it periodically throughout the day. Sometimes they'll use it first thing in the morning to kind of get kicked in a little bit quicker. And they really use it. They really tolerate it. They really like it a lot. And I have some patients who use it and it makes them choke and cough and they try the different, suggestions from the company. I have plenty of patients who tried it and say, well, I didn't really notice much difference. They stopped using it. Believe me, everything is trial and error. And so I think it is good to have as needed medicines. I think it's good to have non-pill medicines. Um, I don't think it's a cure-all or an end-all be-all to for everybody, but I think in the right person, it's a really useful tool in medication. That's my opinion. Great question. So, what are your thoughts about the tests that can be done, not covered by insurance, to determine the best antidepressant for your particular DNA? And I've seen these, oftentimes ordered by psychiatrists or primary care doctors. And my short answer is I don't know. I don't know the accuracy of them. I don't know if they're useful or not, in all honesty. I've seen patients get these tests done, and you're right, I've never seen them covered by insurance, so they are usually out of pocket, but they can basically break down based on your genetics or based on your mitochondria or DNA, which antidepressant or which medicines they think would help you the most. I don't know enough about it. I've never ordered one. I've never suggested one. I've never had sent a patient to get one done. I've only seen them after they've come to me with from other people. But I'm not entirely sure of the accuracy. I'm not sure if they're worth the money. I don't know how much they cost, but at the end of the day, I'm not sure. And so I don't really know the answer to that question. I would probably defer to the psychiatry team. They probably know more about it or use them more, potentially order them more. My question would be is, how do they come up with this information and how accurate is it? If it works, great. What I find when it comes to antidepressants is it's a lot of trial and error anyway. both from an effectiveness standpoint, but also from a side effect standpoint. I've met people who tolerate one medicine and it do great, and then the very next person I see hates that drug because it didn't do well for them, and vice versa. And so I have not been able to come up with a better strategy outside of trial and error to see which one works the best. But if there is more to that, then I think that's something that you'll see more of. And I think the psychiatry teams are probably be the ones who lead that effort. If you have time to talk about, I could talk about constipation for a long time. I mean, at the end of the day, there are whole talks on constipation and Parkinson's disease. The short answer is Parkinson's disease is I'm sorry, constipation is a very common thing in Parkinson's disease. Now, is that because that's where Parkinson's disease starts? There's some evidence to suggest that maybe it does. Is it just a side effect of loss of dopamine? Maybe, but regardless of whether or not it's a trigger, it's a first symptom, it's just closely connected. Constipation is huge in my world. Um, and it's a tough one because people don't like to bring it up. I usually have to ask about it, or it has to be really bad before they bring it up. And it's not exactly something we have great treatment options for. Generally, and this is my own strategy, although again, there's a lot of strategies out there. Um, Anything we can do to keep you out of trouble is important. And so what I tell my patients is the last thing I want you to do is end up in the emergency room because you're blocked up. That's a bad reason to end up in the emergency room. And so usually I'll suggest starting with, if they've already done probiotics, prebiotics, fiber supplements, which a lot of people have, changed their diet, eating a lot more fruits, vegetables, things like that, great. The evidence behind a lot of those things is kind of questionable. I'll usually say start with a stool softener. If a stool softener every day isn't working, sprinkle in a laxative. If you sprinkle in a laxative as needed and that's not enough, then take them every day. If you're taking a stool softener and a laxative every day, then I need to prescribe something. And so that's usually the progression that I recommend to my patients, but that's completely made up. That is just my own experience. That's not based on any paper that I read or anything like that. There are a couple of prescribed medicines that I'll use, Linzess and Amitiza. Lately, for some reason, I found insurance companies seem to be covering Amitiza more than Linzess. I feel like they just flip flop. I also feel like they make stuff up. I can't tell you why. And so I'll figure out which one of those two drugs are better covered by insurance, and I'll say try that. And if we get to that point and you're still struggling or you're still not doing well, then I'm sending you to a gastroenterologist. Maybe they need to do a scope. Maybe they need a bowel regimen or something different. And so again, this is where I am not the end all be all for all of the symptoms that are associated with Parkinson's disease. Even though the constipation is indeed a symptom of Parkinson's disease, doesn't mean I'm the best person for it. And so I oftentimes refer to gastroenterology. Um, and so that's the route that I would go. Um, if that works, great. If it doesn't, then we have to backtrack and think something different. A lot of patients do tell me that sometimes the medicines we use, carbidopa, levodopa, and so on and so forth, they amplify constipation. And so it's a really difficult problem, but it's an important problem because it can make you miserable and it can indeed land you in the hospital if indeed you run into a big block up. And so it is something that we have to keep on top of, or at least try and see if we can improve. And so it's not something you should keep to yourself. If it is a problem, we should figure out what to do about it. What is Paramax? I don't know. I feel like maybe that's something I should know about, but Google knows everything except this. I don't know, Paul. Tell me what Paramax is and I'll look it up for you. If you point me in the right direction, I see anything from wheelchairs to other stuff that doesn't seem to make sense. So give me more to that and I'll look into it for you. My daily regimen involves 30 minutes of stretching, 2 to 3 mile fast walk, 90 minutes of fitness, working with, all right, you're winning. I occasionally experience fatigue. I would probably also experience fatigue after the workouts you're doing. I mean, at the end of the day, you do have to keep that in mind is you are exercising. It is going to make you a little bit tired. Definitely got to stay hydrated. Any suggestions on energy conservation and or enhancement? Maybe, but just understand again, If you're doing that kind of, if I walk for 2 or 3 miles fast and do a 90 minutes at a fitness facility working with weights, balance, core strengthening, I mean, I'm going to be tired too. And I don't think I have Parkinson's disease, although I haven't checked. And so you do have to keep those things in mind. You are still a person, and these things do make you tired. Now, a lot of my patients say that, hey, I burn up more dopamine when I'm exercising or when I'm doing things. And I do try a couple of things to help my patients do a little bit better. Sometimes scheduling your medications around the time of exercise. So maybe taking extra carbidopa, levodopa if you're going to go have an intense workout, I will recommend. A lot of my patients have already kind of figured out on their own that, hey, if I take a pill maybe an hour before I go work out, it kicks in and I feel better. Or if I take something immediately after, then that tends to help too. Because there is some truth to you burning through dopamine the more active an exercise you do, which can indeed amplify symptoms and make you more tired. If that's not doing it, and again, you really want to keep doing your workouts, then sometimes I'll use a stimulant. I'm not against using methylphenidate or modafinil or a stimulant in some of my patients, as long as you don't have major heart or blood pressure issues. And so there are different things you can do. I agree with staying hydrated, and not only staying hydrated, but if you're doing that intensive workouts, you probably need to be eating more. You probably need some electrolytes, maybe a Gatorade or something like that to replace, some of the sweat that you lose, and that might help. And so there's a lot of strategies. One of my personal strategies is, yes, you always see me drink tea, but that's only because we do this late in the evening. But I drink a whole lot of coffee during the day too. That's kind of what gets me through the day and helps me from an energy standpoint. Not that I want you to be caffeine addicts, but everybody finds different things that can help them get through tough workouts. Again, you're doing a great job. Exercise is the best medicine for everything. You're one person that I wouldn't have to yell at, but if you are noticing energy problems, then maybe try some of those suggestions. If you try those things and it's not working, then maybe you need to cut back on the amount of exercise you do. And I almost never say that. More is almost always better. But what I don't like to have happen is you overdo it. It's definitely not a great plan to overexert yourself from an exercise standpoint and then pay for it the rest of the day or the next 2 days, which I've had patients do. So even though I love exercise, that's actually not a very good strategy. And then I recommend maybe doing less, but more frequent. Now, again, you're already doing a lot, you're already doing it fairly frequently. Again, those are probably the suggestions that I would have if you asked me in the office. But maybe try those kind of things. Just keep it in mind. Can you mix Crexont at night with Cinemet during the day? We can do whatever we want. Nobody's looking over my shoulder and telling me I can and can't do things, except for the insurance companies who dictate what I can and can't do. But outside of that, nobody's looking over my shoulder to tell me what I can and can't do. And if we want to mix different versions of carbidopa levodopa, we can mix different versions of carbidopa levodopa. I have some patients that mix Crexont and regular Cinemet or Cinemet and Cinemet CR. And it really is a lot of trial and error to figure out how much of what combination helps you do the best. If you find that the immediate release carbidopa levodopa works best during the day, but Crexont works best overnight, then that's what I'm going to try to do. Yes, it's a lot of trial and error to figure out what that is, but my short answer to that question is we can do whatever we want. We're only limited by side effects and your insurance company. But realistically, side effects when it comes to what we can and can't do. Does staying away from processed foods, starches, and sugary foods help? Um, maybe.
Can't hurt.
Great question, right? There's not a lot written about diet in Parkinson's disease. There's a whole lot written about exercise, but there's not as much written about diet. What is written about diet is that generally the Mediterranean diet is your best choice. Now, how much physical benefit would you notice to a better diet versus mental benefit versus just overall health benefits? I have no idea. I can't think of a single patient that I've had who had a typical diet who really significantly changed their diet and then come back and said, wow, my shaking is less, my stiffness is less, I move better. I don't think they're going out on a limb when they say that the Mediterranean diet is the best diet for people with Parkinson's disease. It's probably the best diet for everybody on the planet. There's a lot of evidence to suggest that processed foods aren't good for you. High sugar foods aren't good for you. A lot of, processed foods aren't good for you. Packaged foods aren't good for you. There's a lot of evidence to suggest that vegetables and fruits are good for you, that whole foods are good for you. Legumes and beans and plant-based things are good for you. Minimizing red meat is good for you. I mean, this is what this is where the Mediterranean diet came from. And there's a lot of evidence to suggest that the Mediterranean diet is just a really good diet for people. And so the short answer to your question is yes, staying away from those types of food probably help. But at the end of the day, I don't know how it would help. Would it just help your overall longevity and well-being? Probably. Would it help you feel better? Maybe, unless you really like sugar and then you're depressed because you can't eat the things you like to do, in which case, no. Do I think it would have a direct impact on your physical symptoms? Less so. But kind of take it with a grain of salt. Everything in moderation. I'm very rare to tell somebody that they really have to go on a strict diet, and I really don't like the idea of cutting out things you really enjoy. That doesn't seem like a great plan to me, at least not a plan for long-term success or happiness. And so everything in moderation, maybe just try cutting it back. Put in less processed foods, less sugary foods, and more whole foods. Basic things like that, I think, are probably good for you and me. And we should all probably do a little bit better at it. Have I seen any evidence that adaptive DBS is better? They're working on it. Personal experience has been very limited. We haven't done that many here at Allegheny, although we're starting to now. Um, I don't know that I've seen papers that compare them head to head. I doubt that you'll see that, at least not anytime in the near future. I think that'll be more of a retrospective kind of review type look. And so I don't know that I've seen direct evidence that adaptive is better. I think it's logically potentially better in the long run, but I can't say that for sure. And I think we still have a long way to go to kind of see how that goes. Pergolide. Okay, so that's Permax. Got it. Was taken off the market. So that I believe is a dopamine agonist, an older one. It was a Parkinson's disease drug that was taken off the market for heart problems, and that's what you were asking about. Thank you, Amanda. See, this is why I have a team. So my thoughts are if it's taken off the market, it doesn't matter what I think about it, I can't get it. This is true for medications that are approved in other countries, but not here. The one that always comes to mind is domperidone or whatever it's called, that is a really good antiemetic, but is not available in the United States. Historically, and whether or not I should tell you this or not, my partner used to send people to Canada for it, but then we got cracked down on that. And realistically, I don't think I have the ability or legality to prescribe a medicine to you that's illegal in this country, even if it is legal in other countries and you want to go to that country to get it. And so if that medicine's been taken off the market, even if it was a great drug, there's not a lot I can do about it. Tilapia and farm fish are fish, but not as good for you. That's probably accurate. I really do think that I would personally benefit from some dietary or dietitian lectures or information. It's not an area that in medical school we get a lot of, and I'll stop there. And Christine, I'll let you read off your last one in a second. But when it comes to medical school, even if you go back to college where you do a lot of interesting classes and basic science stuff, and then you get to medical school and you really learn about medicine, you really learn about body systems, you really learn about what you want to do, and then you get to residency, which is our first line of training of being an actual doctor, and you start actually taking care of people, but you still get a lot of lectures and you still get a lot of teaching. Fellowship, you learn more about your specific training. And then as I've been attending for the past 10 years, going to meetings, you really don't get any good training or a lot of good training in diet, nutrition. And that's really lacking in this country's medical teaching. I feel like other countries are much better at the dietary and nutrition aspect of life. I feel like other countries are just better in preventative health than we are in America. Personally, I really think European countries do a much better job of prevention, diet, exercise, lifestyle modifications than we do in this
Mhm.
country. I feel like that's a big downside to this country in terms of our medical care, but we really don't get a lot of training in diet and nutrition. Everything I've picked up either from people that I've talked to or lectures that I've listened to, things like that. And so it is something that maybe I'm going to spend a little bit more time looking into and come back and give you some more information. I also have heard that tilapia is not a great fish choice for you, but I don't necessarily can't necessarily tell you that, okay, this is why or this is a better fish. I'm not that well trained in diet and nutrition. Um, Here at Allegheny Health Network, we do have nutritionists and dietary people that I can get you to, but I'm going to make it a part of my I wouldn't say mission, but maybe part of my goals here in the next year or so to really do a better job of learning about nutrition so that I can talk to people a little bit better about it. One of my partners, Dr. Cola, is actually dual trained not only in movement disorders but also in integrative medicine. And so maybe I'll touch base with her and see if she has more more insight into diet nutrition. I think she will, and maybe I can bring that back to you guys. All right, Christine, you can go ahead and talk about step forward.
Okay, well, first, let me say that we have, and you're going to be hearing much more about this, but we have formed an amazing medical advisory board at the Parkinson Foundation, Western Pennsylvania. And I bring it up because we have so much expertise across multiple disciplines. And one of those people is Marla Turnbull, who is a nutritionist. She's gone to support groups to present on nutrition, and maybe it's time for us to have another webinar with her where she can talk about diet and exercise and what not to do, as well as what to do. The second thing is we have Step Forward coming up on September 27th. I put some information in the chat, but I just wanted to highlight that you may have seen or heard about Dr. Ray Dorsey in the past. He had a book 3 or 4 years ago called Ending Parkinson's Disease that talks about the environmental factors that contribute to the Parkinson's diagnosis. And he is well aware that Pittsburgh is a hot spot. He is going to be a special guest at Step Forward this year and will do a brief presentation. He will be, we have signed copies of his book that we will be handing out, one to each household. And this book is focused more on kind of the 25 things that you can do to either prevent the onset of Parkinson's or potentially slow the progression if you already are diagnosed. And the food that we serve at Step Forward is from Evia, a wonderful Greek restaurant that serves the Mediterranean diet. So please go to our website to sign up or use the link I put in the chat. Thank you so much.
Have a good one, guys.
Thank you.